name is Dr. Raevti Bole, and I'm a faculty member at the Department of Urology at the Cleveland Clinic.
Hi, I'm Juan Andino. I'm faculty at UCLA and affiliate at Martin Luther King Community Hospital. It's great to be here with you all today. And Dr. Bole, pleasure to spend some time talking again about an important issue that impacts our patients. Give us a little bit of context. Surgical treatment for erectile dysfunction, what does that entail?
Yeah, great question. I think in this day and age, surgical treatment, the gold standard for severe erectile dysfunction is going to be with a penile prosthesis. Now, far and away the most popular device in the United States is going to be the inflatable version, the inflatable 3-piece penile prosthesis, which is the most durable treatment for this and with far and away the highest patient and partner satisfaction.
Yeah, and tell us, this is a topic that used to be more taboo. Patients now are feeling more comfortable talking about it, but it is an elective procedure. What are some of the risks? What are the things that you worry about as a surgeon who does these advanced treatments for erectile dysfunction?
Yeah, I think for any of us prosthetic surgeons, the main thing that we worry about is device infection. That's going to be something that really affects the quality of life for the patient who has recovered from the surgery and with an infection is facing having to have the whole device removed, the space washed out, and then a period of healing and waiting until they can potentially salvage their device in many cases. So that would be a terrible event that we all try and avoid.
Well, Dr. Bole, tell us a little bit. Obviously, you're a patient, you're learning about this, you hear infections, something's going in the body. Give us some context. How have things changed? Have we gotten better as a field, as urologists, at minimizing the risk of infection?
We have. So I would say prior to the early 2000s, as you know very well, all of our infections, or the vast majority, were from mild skin bacteria, staph, epidermidis, and the like. And they cause these delayed presentation of symptoms, localized infections, really limited to the area of the scrotum and the pump, perhaps. After the early 2000s, when we got the infection retardant coating on virtually all the devices that we implanted, the profile of those infections changed. And we both know that there have been a lot of multi-institutional studies looking at this, where we're now seeing much more virulent organisms, more fungal infections, and really just very toxic clinical symptoms when an infection does occur, so high fevers, purulent drainage, and such. And that really causes a lot of problems when we do get that rare infection now. And it is rare, but there are certainly steps that we want to take to try and even prevent those from happening.
Yeah, that's exactly right. And the field has to keep moving forward. And I'm really excited to be with you here today because some of this research that we're going to talk about was actually possible because of a grant from the SMSNA. So it's great to see how the clinical practice leads to research questions, and then our society is able to promote the research that's going to reduce these risks even further and kind of understand how do we make this even better moving forward. So let's jump in. Let's talk a little bit about your research. We got some background on the implants, on the infections. Tell us a little bit more about what this research was focused on.
Yes, so the authors of this study did a fantastic job at characterizing biofilm. So biofilm is important because it's something that makes infections in IPPs and other implanted devices very difficult to treat. So biofilm, as we both know, but certainly something that's not always talked about outside of the prosthetic community, is comprised of microorganisms and their metabolites living in this slimy matrix that really protects them while they're in place. And we know that it takes about 1,000 times the dose of antibiotic to kill bacteria that are living within a biofilm as opposed to free floating. So the authors did a really detailed analysis of biofilm on IPPs in an effort to try and study potentially novel pathways for treating these infections in future.
That's fantastic. And these implants that they looked at, that they studied, was it patients who had infections? Was it just people who needed a revision or a new surgery? Tell us a little bit more about that.
Both of those, actually. So they were able to study infected devices, and actually the majority of the patients in the study had their devices explanted for non-infectious reasons. Okay. So they were able to look at both. And they did a really nice analysis of how the biofilm composition was similar in many ways and then differed in some ways across infection status and actually also across device manufacturer. And one thing that I thought was a very good strength of the study was that the device manufacturer was anonymized, and so really they tried to limit the risk of bias there from knowing what each device was.
Yeah, and that's really interesting that even on these non-infected cases, there was this biofilm, these bacteria. It makes me think of, people used to say urine is sterile. And now as the field of medicine in general is getting better information, we're learning that no, actually most of our body has different bacteria, but what's good bacteria, what's normal bacteria, what's going to cause issues. Do you feel like studies like this are going to give us more insight into, whether these biofilms, what makes up these biofilms, can change the risk profile of the types of infections that we get?
Absolutely. I think this gives us a lot of information because, as you said, even in devices that we know are clinically infected, about 30% of the time you're not growing anything in a standard culture taken using a standard swab. And so there's so much that we can learn from a study like this where, yes, we were able to see biofilm in the result of virtually every device that was studied on electron microscopy. So that was really neat.
Well, Dr. Bole, you talked about the methodology, the biofilms, the importance of all this work. What did the group find?
So there were some really interesting findings, and I think they actually focus on what was similar among the devices. They found an abundance of certain phyla, both in the viral world and the bacterial world. So in the viral world, they actually found a certain phylum of viruses that belong to the pox virus family, so the kind that cause skin lesions. And they're also seen in the lungs of patients who have COPD and in urine. And so that's interesting because we don't really know the implications of that. Is it possibly some sort of ancient virus that's been incorporated into the human genome? Is it possibly a remnant of the smallpox vaccine? I think more to come, and that's just something that was noticed in this study. But perhaps more importantly, the most abundant bacterial phylum that they found was proteobacteria. And we know those comprise some of the most pathogenic bacteria that we know, Escherichia, Klebsiella, and these were seen abundantly in infected devices and in non-infected devices. And I think the implications of that are very interesting because perhaps clinical infection is not driven so much by, overexpression of one particular bacterial species. Perhaps it's more of a loss of equilibrium or a dysbiosis. So a change in our understanding perhaps of how infection evolves.
That's fantastic. Thank you for summarizing that. And yeah, I wouldn't even think about a virus on the implant. So that is really cool work, and to be determined what that means in the long term. So we've talked about the study itself, some of the results. What are some of the next steps? What are some of the things you're hoping to see down the pipeline related to this type of research?
Yeah, I think, as you said before, support from the foundation is so important to lead innovation in this space. I'll be excited to see what other differences they find with infections and really being able to hopefully target how to treat some of these infections in future for the good of all of our patients.
Yeah, that's exactly right. You have to understand the problem to even start figuring out what are the solutions and long-term steps that we can take to make things better for patients. Well, thank you for your time. Thank you for summarizing that very interesting study.
Thank you.
It was a pleasure getting to go over it with you.
Likewise.